Welcome to ClinicalMedEd Clarity. In this episode, we untangle 5 words which get used loosely every day during clinical rounds on the wards. And those 5 words are infection, SIRS, sepsis, severe sepsis, septic shock, and multi-organ dysfunction syndrome or MODS. In fact, severe sepsis I just added, we'll come to that. So basically 5 words. Now we will map them into a single spectrum, apply the current Sepsis-3 criteria, and clear up why the severe sepsis, which I referred to just a little while ago, has been retired. So basically we have 4 learning objectives for this episode, this video. First, clean definitions for the whole spectrum as I just said earlier. Secondly, apply the operational rules for sepsis, which means an acute rise in qSOFA of 2 or more. We'll come to that. Third, spot septic shock at the bedside using Vasopressor and Lactate thresholds. And fourth, understand why the old terms of severe sepsis, the phrase it was abolished, and it is a favorite exam trap. So what is the sepsis spectrum, as we just briefly touched? So think of the terminologies used here as an escalating spectrum, not separate disease or condition etiologies per se. So it starts with infection and then it ends with multi-organ dysfunction syndrome. Obviously, infection means the microbes are present where they shouldn't normally be. Then SIRS sits in between, and it was sitting there historically, which is a non-specific inflammatory response. We'll explain that, and then we'll just set it aside because it's not in use anymore. Sepsis is the pivotal step, number 3, which means infection has now caused organ dysfunction, and that is crucial. And septic shock, a step up from sepsis, means now it's dangerous category with circulatory and metabolic failure. We'll discuss later. And finally, the multi-organ dysfunction syndrome or MODS is the far extreme end, which means progressive failure of multiple organs. And the single thread tying the modern definitions together is the organ dysfunction. And this idea will hold on to for the rest of the episode and the further clarity series. Let's look at the infection and the SIRS era, where the spectrum begins in the framework we just left behind and what are we using currently. So basically the spectrum, as we saw in the last slide, begins with infection, which means the microorganisms are invading the tissues where they should, which they should normally be sterile. So this means once they invade the tissue, it evokes and provokes a host response. Now, this is different from 2 other categories, which are number 1, colonization. So, colonization is the presence of bacteria or microbes without evoking any host response. Maybe they're just there as a colony. Think of them like this. And the other one is what is called contamination. So, contamination is when the microbes are present in the sample, not inside the patient. Now, for 2 decades, we framed the systemic reaction using SIRS, and the SIRS included, if you can recall, 2 or more of the following criteria. So, pyrexia at above 38, temperature more than 38 Celsius or less than 36 Celsius, a tachycardia or a heart rate of above 90 per minute, tachypnea with a respiratory rate of 20, or partial pressure of the carbon dioxide in the arterial blood to be less than 32 millimeters of mercury, which again implies hyperventilation, tachypnea, hence you're blowing off the acidic gas or CO2. And finally, leukopenia or leukocytosis with the counts of less than 4 or above 12. Now, the problem with all this is the specificity. Why? Because let's say if there's a marathon runner or any patient who comes with acute pancreatitis, not due to infection, they would still meet the SIRS criteria. And this means there is no infection at all. So this SIRS in this particular spectrum is technically sitting it as a misfit entity. And that non-specificity of SIRS exactly is why the Sepsis-3 moved away from it. Coming forward to 2016, the redefinition of sepsis in the Sepsis-3 consensus. So this is the shift from inflammation to organ dysfunction. That is a key ethos. That's, you just have to remember that. So in this 2016, the 3rd international consensus, what was Sepsis-3, it redefined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. So this is important. It's not the presence of infection. It's actually the response of the host body, which is actually dysregulated, which leads to organ dysfunction, which eventually can be life-threatening, and this is sepsis. So you have to read it in reverse. Infection leading to host response, which is dysregulated, which leads to organ dysfunction, which can be life-threatening. This all equals sepsis. So I think this is a better way to understand it. Now, if you read it in a more technical sense, the center of gravity has now moved away from how inflamed the patient looks to whether their organs are failing. And that is the bottom line. Now, once you understand this, then you will be able to pick up why the SIRS and qSOFA were moved out. Because SIRS measured the reaction of the body, but it's the dysregulated host response and hence the organ failure which leads to, which actually kills the patient. And that is important. Now, so that's why the definition now puts organ dysfunction at its core. And this single conceptual move from inflammation to organ dysfunction actually led to the death or demise of the qSOFA as a screening tool, and also the death of severe sepsis as a terminology. So sepsis operational rule. Let's see, here's how the concept becomes a decision. Sepsis equals suspected or confirmed infection plus an acute rise in the SOFA score of 2 or more points. So please don't confuse. We're not talking about qSOFA. We are talking about the SOFA scores. And the SOFA assesses 6 organ systems. You might have your own way of doing it, but I love doing mnemonics. So I've just come up with a structure that helps me and works for me. I'll just share with you. So the 6 organ systems and what it measures. Heart. Think of cardiovascular, the most important vital organ, or one of the most important, cardiovascular system or heart, assessed by mean arterial pressure or and also the vasopressor need. Lungs, respiration by the ratio of PaO2, arterial partial pressure of oxygen, to FiO2, which is inspired oxygen. Then heart, lungs, next one is the liver by bilirubin, and behind liver on each side and behind the in the renal angles under the rib cages, we have the kidneys. So renal by serum creatinine or urine output. And the master organ of all is the brain. So CNS by GCS. And the final 6th organ is the coagulation or the vasculature or the blood. So think of the blood which connects all these organs together, all the vital organs. So the coagulation we assess by the platelets. Now we assume a baseline of 0 for every patient unless a patient has known pre-existing organ dysfunction. And 2 points above the baseline in the context of infection is actually sepsis. That's it. Now this is one of my very, very favorite slides and really important concept. So screening does not mean definition. And in 2026, currently in this year, the bedside tool has literally changed in March in the 2026 sepsis guidelines, which I've done a separate video on, and there will be further clarity series. 2 vital distinctions, as I said, do not confuse screen with the definition. Okay, so SOFA, the SOFA score, remember in our previous slide, it defines sepsis, while a bedside screen or a screening tool only tells you who to assess more closely for sepsis. So it's a screening tool. Screening tool versus definition. Now, the screening tool does not rule in or rule out sepsis per se, because sepsis is a clinical diagnosis. That distinction is number one. And secondly, even the bedside screening tools have changed. So the qSOFA arrived alongside the sepsis definition, which was part of Sepsis-3 consensus in 2016, which we just touched upon. And the qSOFA included 3 criteria: respiratory rate more than 22 or more, altered mentation, and number 3, systolic blood pressure of 100 or less. Any 2 of the 3 criteria, the score was considered positive and high risk. Now, this is too insensitive as a criteria. So, in 2026 guidelines, exactly 1 decade after the 2016 qSOFA application, the guideline recommends qSOFA out and NEWS 2 in. So this means the NEWS 2 or MUSE early warning scores, whether it's National Early Warning Score, National Early Warning Score 2, Modified Early Warning Score, or anything similar. So they are preferred over qSOFA as a single in-hospital screening tool. And that's a strong recommendation at moderate certainty. Now, of all these screening tools, News2 performs the best because it has a sensitivity of around 73%, unlike qSOFA, which has a sensitivity of roughly 51%, which means 1 in 2 or almost half of the patients can easily be missed. We'll properly discuss about all these scores in our Clarity episode number 2. And further exam twist for different clinical exam scenarios. SIRS, which we retired from defining sepsis back in 2016, is still a valid screening tool today. It is more sensitive than qSOFA. That's the whole point. Screening and definition are different jobs. Do not mix them up. Now, coming to the real definition of septic shock. So septic shock is sepsis plus 2 of the criteria which both must be present. First, the patient needs vasopressors to keep their mean arterial pressure of 65 or above, and that's after adequate fluid resuscitation, not instead of it. What it means? That it's a fluid resistant hypotension. Number 2, the serum lactate is above 2 millimoles per liter, indicating tissue hypoperfusion, and this is despite the fluid resuscitation. And obviously, once you've done fluid resuscitation, the lactate is still high, then you need vasopressors. That makes sense. And the exam trap is the word both. A patient, for example, if a patient is on vasopressors, but the lactate is normal, or on the other hand, somebody who has got high lactate without the use of vasopressors, this doesn't fulfill or meet the criteria for the definition. So septic shock identifies the sickest subset of sepsis patients with in-hospital mortality as high as around 40%. So why is septic shock a distributive shock? So think of our Brady as one of the mascots for this concept. So distributive shock means there is a dysregulated host response which drives widespread vasodilatation. So the slowing of the circulation, our Brady. This drops systemic vascular resistance, SVC, and that leads to maldistribution rather than a homeostatic AG dove. Think of the homeostasis being totally disturbed. So now the vasodilatation leads to dysregulated response, and that leads to capillary leakage. Now the drop in systemic vascular resistance and the maldistribution of blood flow leads to tissue underperfusion of the tissues, even when the heart is pumping plenty. So it's tachycardia trying to compensate, but it's not the cardiac problem per se. It's more of tissue perfusion and the rising lactate. That's why it's a classic warm and vasodilated shock pattern, unlike the hypovolemic and cardiogenic shock, which are cold and clammy. So warm vasodilated versus cold and clammy. It also explains the treatment logic. No matter how much fluid resuscitation you do, it's a distribution problem. So that alone will not fix the problem unless it's very early in the condition and you aggressively hydrate or reasonably hydrate and the patient recovers. That's why restoring the systemic vascular resistance with the use of vasopressors, appropriate use of vasopressors, will restore the systemic vascular resistance, and that sits alongside the fluid resuscitation in such patients. Severe sepsis, why was it totally retired? So let's look at it. Before 2016, we had a 3-tier model. I still remember when I was training in the Northern Deanery in the United Kingdom during my higher specialist training. In fact, I did a sepsis workbook during my diploma in medical education qualification from the Cardiff University, and I precisely remember this was the terminology we used. So sepsis was infection plus SIRS. Infection plus SIRS equals sepsis. Then sepsis plus organ dysfunction equaled severe sepsis, and then severe sepsis leading to refractory hypotension, not fluid responsive, that was septic shock. So this was the 3-tier structure or strategy. In Sepsis-3 in 2016, the consensus, they folded the whole organ dysfunction category into the definition of sepsis itself. And that meant that the severe sepsis category in the middle totally became redundant and was formally abolished. Why do you still see it elsewhere or everywhere, to be honest? Because the coding systems for the hospital coding, especially the Sepsis 1 bundles, they never got fully caught up. So it still persisted on charts and in audits, which I think some hospitals might still be using them. So the take-home message: recognize it when you read it, know what you mean by it, but do not use the severe sepsis definition clinically or in your exam answers as a purist. However, a disclaimer: anybody using this terminology based on your hospital policy, institutional policy, local guidelines, just kindly follow them. This lecture is purely for academic purposes. It's not to replace the systems in place that you're already working with. And after septic shock, on the other extreme of the spectrum, we had discussed the MODS, multi-organ dysfunction syndrome. This means there is progressive, potentially reversible failure of at least two or more organ systems, vital organ systems, in an acutely ill patient. It's not a separate disease entity or condition itself. It's a trajectory along the same continuum from infection to sepsis to septic shock and now leading to multi-organ dysfunction. So it's a progressive phase, progressively rising phase. The usual suspects in all these organs, please remember the mnemonic that I told you: heart, lungs, liver, kidneys, brain, and then the circulation represented by the platelets. So the MODS is reflected by cardiovascular system as shock, MAP, and all the definitions that we said in the high lactate, in lungs as ARDS, in liver as rising bilirubin, hyperbilirubinemia, and kidneys as acute kidney injury. The definition could be rise in serum creatinine and or urine output tailing off. Brain as encephalopathy, and the clotting system or consumption of platelets leading to DIC. Now, the more the systems are involved, the higher the mortality. And that is the whole argument of recognizing sepsis early before this cascade is evolving into multi-organ dysfunction. So a quick word on the SIRS versus Sepsis-3, which we had discussed many times in this episode. So let's put the two frameworks side by side for better clarity. SIRS is built on the inflammatory response, two or more of the temperature, heart rate, respiratory rate, and the white cell count. It is sensitive but non-specific. That's why it has been retired as a staging tool. On the other hand, Sepsis-3 since 2016 is built on the concept of organ dysfunction, not inflammation. Organ dysfunction, which means infection plus SOFA of two or more. And it's more specific, and it's a standard that you should be quoting today. And the one-liner to remember, which I have discussed earlier also, that SIRS tells you how the body reacted. That's an inflammatory response. But Sepsis-3 tells you that the body is failing due to organ dysfunction. And this distinction alone is the heart of all this entire episode of sepsis. Finally, examiner pearls for MRCP USMLE exams. Number 1, infection plus SIRS is not sepsis as we used to have pre-2016 era. You need evidence of organ dysfunction, which means a SOFA score of 2 or more with the clinical suspicion or evidence of infection. Number 2, septic shock needs both requirements. Number 1, the vasopressor requirement and high lactate of above 2. Both should be present. Presence of just one alone does not qualify the definition of septic shock. Number 3, severe sepsis is no longer used in literature because it's totally outdated. Only recognize it when you see it because it's still used in the coding system, especially in some of the US hospitals for billing purposes. And number 4, qSOFA, NEWS and NEWS 2 are all screening tools. They are not definitions of sepsis. And do not confuse a screening tool with a diagnosis of sepsis. And the last slide, the spectrum in one view. Infection triggers a host response. SIRS was the old non-specific lens, which is outdated. Sepsis means infection plus organ dysfunction by SOFA criteria. Septic shock is the subset which needs pressors and a raised lactate. And finally, the MODS is the far end of this spectrum.